Go live now.
Hey, hello. Good afternoon, everybody. Allow me to introduce myself. I'm Dr. Liu. I'm a vascular surgeon from Kuala Lumpur. We are very glad today that we have yet another webinar, and this time is a really technical webinar. We will be speaking on the new product. There's a tri-wedge balloon system. And this evening, we're very lucky because we got three eminent speakers from Malaysia and also from China. They're going to share their experiences. And to start off, I think, let me introduce the coordinator, rather the moderator. So the moderator we meet today is Professor Qin Qi-Chuang. Qin Qi-Chuang is from Beijing. And another moderator is Dr. Lim Bin Kiat. He's a vascular surgeon in Kuala Lumpur. I think together we will try to introduce the speakers, and I'm very glad that Wang Pei is here. Hi, Dr. Wang Pei. Good afternoon. Can hear me? All right, that's not matter. Okay. So, hey, great. So what I will do is okay, great. So maybe what we'll start off. Let's not waste more time. We will start off with. I'll pass the mic to Dr. Lim Bin Kiat, and he'll start off with this webinar. Dr. Lim?
Hi. Good evening, everyone. Good afternoon. I'm Dr. Lim. I think our first speaker is Dr. Saravana. He's actually my colleague. He's at the Gleneagles Hospital, Kuala Lumpur, as well as Pantai Hospital. I think he's got 10 years of experience in vascular surgery, and I think his main interest is in peripheral vascular disease, lower limbs, besides other aspects of vascular surgery. And also he has gave quite numerous talks. Today, Dr. Saravana is going to talk on tri-wedge used in AVF surgery. Okay, Sarah, over to you.
Thank you, Dr. Lim. Sorry, am I muted? No, okay. Thank you, Dr. Lim and Dr. Prof. Liu for introducing me. Thanks everybody for joining us today for this live talk. I think we are here to talk about tri-wedge balloon and thing. I guess I think everybody has the schedule, so just proceed with sharing my screen. Hi, can you guys see my screen?
Yes, Sarah. Yes.
Okay, thank you. So as Dr. Lim Bin Kiat, as mentioned earlier, I'm actually working in a hospital in the city center in Kuala Lumpur. It's called the Beach or Pantai in Malay, but it's not located anywhere near the ocean. It's actually up on a hill, in fact. So it's a 500-bedded hospital. So a brief introduction about our problem. With any intervention for AVF, the main pathology is always the luminal stenosis. It is induced by inflammatory process because of repeated cannulation, leading to neointimal hyperplasia, smooth muscle migration, and unfavorable venous remodeling. Essentially, it's a fibromuscular thickening. Now, traditionally, we have used balloon, plain old balloon, and from normal pressure balloon to high pressure balloons. And most times, I reckon, whether it's here in Europe or in anywhere part of the world, we have experienced that patients keep coming back for early re-intervention. This is probably because of profound inflammatory reaction that is produced by these traditional balloons. Now, I think there is a technological change where the introduction of cutting balloons and scoring balloons have been brought in, and cutting balloons have actually been there around since 1980s. I was actually shocked also. I forgot that it's been there quite long, and it's used using some razor blades, 3 to 4 arthritomes located on the balloon, and it can be used in the coronary in the beginning. But Wowek in 1995 started using it in fistula for the first time. Now, scoring balloons concepts, I think, came about 2003. Basically, a balloon with a wire either coating the balloon on one side or two sides initially, but with tri-wedge, it's now come up to 3 3 wires running on the surface of the balloon. Okay, it's been used in fistula. The principle of cutting and scoring balloon is to minimize elastic recoil and inflammation, and at the same time maintain human patency, hopefully without the need for stents. Now, conventional balloons in dialysis access, we get about 6 months patency, about 50 to 60%. And single lesions, as compared to 2 or more lesions, we find the patency rate actually drops because you have to deal with longer segments of lesions. Also, be aware that when we treat repeated stenotic lesions, it doesn't improve the patency with the subsequent intervention. Actually, the patency rate comes down even further. Drug coating balloon has been a boon for us, and we have started using it quite some time now, and the patency for 6 months ranges from 70 to 97%. But personally, I experienced about 70% in 6 months, but about 8 months, I start seeing a higher number of needing for re-intervention. Now, cutting and scoring balloons, if we look at the literature, it shows a patency about 70 to 86% at 6 months. Now, the price of scoring balloon is about 2/3 of a DCB. So we do consider for those price range in between that we may consider scoring balloons as an alternative for DCB. And the other issue with the cutting balloon is also that they are usually of smaller sizes, about 20 mm, and that means it translates to longer procedural time. So may take us longer to complete our case. And then, of course, the question whether we should combine scoring balloon with DCB. Now, I'll start sharing my cases. The first case is a 66-year-old male who presented, who had a BCF created in 2019, of course, with the classic diabetes and hypertension. Presented during our COVID period in July 2020 with dysfunctional fistula. He had high venous pressure, prolonged bleeding. So we did an ultrasound, showed some outflow stenosis, not sure it's thrombosis at the cephalic arch. So we proceeded with the fistulogram and plasty. So this is just a snapshot of an image of the fistulogram which was done. Actually, there is a cannulating segment stenosis as well as the outflow stenosis. So what we did is basically put in a Mustang balloon at that time with and followed by a DCB balloon. However, also a conquest balloon to the cannulating segment. We got good flow. Patient went back home, was able to use for dialysis. However, fast forward 9 months later, he presented with thrombosis of the same fistula. So this is during the COVID period and things. So patients don't come regularly follow up. Usually they come when there's a problem. So what we did is we had to use a crossing device to cross it, and we were able to get our fountain catheter, which is to use for catheter guided thrombolysis. And we thrombolized him for about 15 to 20 minutes. And then we got, sorry, this is the pre-catheter crossing. So as you can see, there's a missing outflow before the catheter was crossed. Then we were able to cross with the guiding wire, and we were able to put the fountain catheter across to enable the urokinase to be delivered. And subsequently, we used a tri-wedge balloon, a 6x40. This is one of my early experiences with this balloon. So I just wanted to use a tri-wedge balloon as a solo device, solo balloon, sorry. So, and we plastied that area. And we got a good result, fairly good result, I would say. We got the fistula flowing again. And we thought everything was in the clear, and the patient was supposed to come back for follow-up subsequently 3 months, 6 months. Now, about 6 months after we did the procedure, I did scan him and I found the plasty to be good. The flow was good. And we continued him on cardioprin at that time. And he presented another 6 months later with high venous pressure. And this time the pressures were about more than 180. And again, he had prolonged bleeding from the cannulation site. So again, we proceeded for fistulogram. And this time we found the stenosis actually starting to migrate more higher up. And this time the decision was made for stenting because the patient couldn't keep coming back for follow-up. And also it was an issue with COVID. We didn't want to re-intervene in a very short time. So what I learned from this particular case is that the disease, as we plasty a previously plastic disease, it doesn't get easier, it actually gets harder. Even though the morphology or the histology is the same, the treatment may also need to be picked up. We need to improve the techniques or improve the way that we plasty these lesions. Now, case 2 is a 74-year-old male. This patient presented with uremic symptoms in December in 2020, and he underwent a perm cath insertion or tunnel catheter insertion for dialysis. And subsequently, just before discharge, a fistula was created. And post-procedure, the fistula on follow-up was failing to mature, and patient was advised for balloon-assisted maturation, but he refused, and he kept waiting until February. So, which is about 3 months later. So subsequently, we did a fistulogram. This was a downhill approach or retrograde approach, and we crossed over to the artery. And I saw the lesions. There was a lesion in the cannulating segment. There was a lesion in the swings, the juxta-anastomotic area, less than 5 centimeters from the anastomotic point. And I proceeded to use a 5 mm tri-wedge balloon. Again, the aim was to just use single balloon, but from judging from previous experience, I was also always keeping in the back of my mind whether I will go ahead with a drug-coated balloon after this. So we did the plasty across the juxta-anastomotic point and also across the anastomotic point. And I would not have done this with a cutting balloon because of for the reason. And what we found that the most commonest site for fistula failure is basically, or fistula failing to mature, is the anastomotic area or the swing segment, which is the less than 5 centimeters from the anastomotic point. And you need a minimum diameter of 2.7 mm to have a good inflow of a 2.7 millimeter and above, provides the best fistula flow. So we did a run after all that tri-wedge, and we got a good antegrade flow. And I followed up the patient up to 6 months late, about November 2020. Sorry, I think the dates are wrong. Okay, 2020. And what did I find? The patient ended up having a thrombosis about 6 months later. So at that time I was questioning myself whether I should have used the DCB balloon post-plasty, and this was a primary intervention, no previous plasties done. So this is another turning point for me as well, and my practice as well. So case number 3 is a 51-year-old female with a history of right BCF thrombectomy, done 9 months prior to seeing me in another center, and the fistuloplasty was done to the outflow vessel. Patient is also a known case of ischemic heart disease with atrial fibrillation on epizaban. So he's already on anticoagulation, and despite that, he presented with a restenosis. And this time around, the QB, or what we call as a pump flow, has been dropping to less than 200 mils per minute, and the nurses were having difficulty to dialyze this patient. Sorry. So looking at this image, one would think this is a downhill approach or retrograde approach, and as we cross over the artery, we notice that the stenosis is quite tight. Now, I only have the tri-wedge balloon, and we have an access to get a peripheral cutting balloon, or we would to use a Scoreflex balloon or ultra-score balloon. But what I looked at, the higher the pressure that you can achieve with the tri-wedge is about 20, whereas the rest of the balloons don't seem to hit that amount. So if I needed an extra boost or an extra ATM to dilate the vessel, I would actually have to go with the tri-wedge. So the decision in this juncture I made is to use a tri-wedge. And at the same time, I've always wondered whether the balloon will cross with all that wire on its surface, whether it's pushable or trackable across the anastomosis. And knowing that the configuration is that the balloon is folded across the scoring wire, it should be protected, and so it is able to cross. And true enough, I was able to cross. I did the tri-wedge plasty across the anastomosis, and this is a 5 mm by 40, and this is the result I got. And subsequently, from all the other two experience of not putting a drug-coated balloon, I followed this with a Ranger, use a Ranger balloon, and Ranger balloon 6 mm by 80, and following that, this was the final run after the balloon drug coating balloon angioplasty was done. Now I've reviewed him 6 months later. He's able to maintain good dialysis at the moment, and no issues with his dialysis at the moment. Okay, and my last case for discussion for today is actually an 81-year-old male who presented with a known case of CKD. He presented with acute failure symptoms. He came in as emergency. Again, a temporary catheter had to be put in, and after he was stabilized, he left here with a left radiocephalic fistula. The problem with this elderly gentleman was his fistulas in the upper limb were all complex. There's no avenue to do a superficial cephalic vein. So the only alternative was the left radiocephalic vein. Even though the artery was about 2 mm in size and the vein was just borderline, I proceeded to do the left radiocephalic fistula. Now, fast forward 2 months later, I scanned him again. The fistula still did not mature. It's about 300 to 350 mils per minute. And the average diameter of the vein was only about 3 mm to 4.3 mm. So if you can see this video, that this is with the inflow compress. It's a retrograde approach. You can see tight stenosis all the way. And we were able to cross it with our wire, 018 wire. And I did a arterial run, and I decided because I wanted to minimize the inflammation and minimize the inflammation from using the regular high pressure balloons. I wanted to use a scoring balloon on this. So yeah. So again, choose tri-wedge for this case. This time around, I used a 6 mm by 40. And this is the run. I mean, this is the tri-wedge balloon expanding itself. Now, one of the things I realized is I really have to look very hard, mag it a few times, and look for actual effacement. Sometimes you see the balloon expanding, but it's not really effacing. So you need to keep a close eye on the effacement. So I'm not sure whether you all can focus on this area. Suddenly you see the sudden bulging out, and that is probably the tightest spot that I had to do. And so after a few plasties up and down, I got this result, and the patient went back home, and the fistula flow was much better now. I just saw him today. He came for follow-up, and the fistula is almost 6 mm at the moment, and he's able to use the fistula for dialysis today. So these are some of my experiences using the tri-wedge balloon. And some of the lessons that I learned from this is I think there is a need for, even after plastying with a scoring balloon, that we still need to use another form of device, which is the drug-coated balloon, to prevent the early recurrence and also reduce the inflammation that occurs over that area, so to maintain the patency of this fistula. It requires less pressure to open a stenotic lesion with scoring balloons as compared to my usual experience using high pressure balloons and going up to 20 to 30 ATMs to actually open the balloon. Pushability across stenotic point, I found it easier, especially because the wire is well wrapped by the balloon pre-deployment. So even if it's a tight stenosis, I'm able to negotiate. I don't have to, at most times, I don't have to pre-deal to get my balloon across. Thank you.
Thank you, Dr. Saravana. Okay. That's very interesting talk. I think if there is any question, maybe you all can put forward. Maybe I'll start off by asking you a few questions. You're saying less pressure is needed to inflate. Do you find that with the less pressure, the pain is more tolerable for the patients, or I know it's a bit difficult to assess that because different patients have different pain threshold, so it's very difficult to assess the pain.
That's an interesting fact, Lim, because I try to do my patient mostly under local anesthesia. I do give sometimes local infiltration around the area that I'm going to balloon, but I find if I give too much, then the balloon has to work against the edema from all that local anesthetic. So I do have patients who are anxious. I do them under sedation. So I really don't know what the pain level is, those with under sedation, but those with under local anesthesia, I found that the high pressure balloons actually cause more pain, because I think there is a lot of adventitial hematoma and things, so that causes a bit more. And bruising, I find, is much more with the high pressure balloons.
Anyone has any question? Please, please feel free to ask. The other thing which I want to ask you is, are you using the low profile balloon? And I know there are 018 and 035 profile. I notice you use 0181, but do you find if it is a tight lesion, the 018 wire will be a bit difficult to cross with the 018 wire?
My traditional workhorse wire is the Cook Glide. I use that most of the time, the 035 platform. Very rarely I have to go to a 018, and I find sometimes the 018 tends to melt shape most times when I cross over, whereas with the glide wires, I don't seem to have that problem. So most of the time I get away using a 035 platform. With 018, I've not used a tri-wedge on a 018, but I use that 018 wire to cross to get my catheter down. Then I exchange it with the 035 wire and deployed my balloons over 035 wire.
Yeah. Any questions from anyone?
Haris here.
Yes, Haris.
Yeah, excellent talk, Sarah. I think it's quite nice to see your outcome. I mean, for me, I have just started using tri-wedge for AVF. I mean, not much experience, but some of my early cases, I find that for example, very tight stenosis, very heavily. Some of them are quite calcified because the pressure is only up to 20. So some of them I still cannot open with the tri-wedge. So, I mean, in your experience, do you still have to need a backup like a Mustang high pressure or ultra high pressure kind of balloon as a backup, or perhaps cutting balloon?
Yeah, like all of us, I think we have what we have on the shelf. We function like that, but I think cutting balloon is a good alternative, except in certain areas where you can't use the cutting balloon, wherever there's more than 45 degrees angulation and you can't use the cutting balloon, or there's a stent nearby and you don't want to get the blade caught in the stent. Other than that, I've used only once the cutting balloon before. The most times I try to get away with the conquest balloons or those with the Kevlar balloons to open up the very tight lesions. But what I saw in my experience with this tri-wedge balloon is sometimes you just have to be a bit patient and keep inflating it. And sometimes with rapid inflation, you get different result, but sometimes with slow inflation, you get a different. I've noticed these things as well. I don't know, maybe it's just luck, but you really need to look for that wasting effacement. If you can see that, you got a good result. But if you get a lot of recoil, I think you should consider either upsizing, or you could use the cutting balloon, which I think it's a shorter balloon most times, and it cannot inflate very high. It's about 6 ATM, or I believe it's about 6 ATM. Not too much experience with cutting balloons though.
So in terms of the inflation of this tri-wedge, what do you recommend? I mean, for AVF, so it's just a slow inflation, right?
Well, basically the balloon is unfolding over the wires and you're slowly deploying the thing. But once the balloon is deployed and you deflate it, it's not going to, the wire is not going to mysteriously refold itself under the plastic wrapping. So it's already there. That's when I find that crossing any lesion might be a bit difficult once you've already used that balloon the first time, you know. So apart from that, I have used the balloons in a way that I know that it's supposed to gently cut. It's not supposed to really tear the thing. So I don't expect the tri-wedge balloon to do very well above the 20 ATM. So I wouldn't recommend it.
Yeah, and the other thing, like cutting balloon, so you can twist it to make it cut at a different angle. So like this tri-wedge, you got the 3 wires. So do you twist it and then make it score in a different angle? Is there any advantage of doing that? What do you think?
Personally, if I can't dilate, I mean, I can't stretch it in the first instance. Even if I twist it, I don't think it does much different. Actually, I've not. It's unlike, like, you know, if you're dealing with a calcified plaque or something, it's a bit different whether you're trying to really score that particular area. But in a fibromuscular intimal, this one is going to be almost circumferential, and it's most times even cutting at a different position. I don't think I've got much different. I have done that. Actually. I've rotated it, trying to see whether it cuts. But this is like 360 degree, and you have every 120 degrees you have a wire sitting there. So odds are you're not going to miss much. But if you use the earlier balloons, scoring balloons, which were only 1 wire, or the ones with 2 wires, maybe you could consider that. But now with this 120 degree angle, this one, I think it's less likely for you to miss that areas.
I agree with you. How about BK? What do you think? I mean, I think you have quite a lot of experience with the AVF as well.
Yeah. The question that you brought up about the high pressure balloon, the fact that the tri-wedge only can go up to 20 millimeters of mercury, but actually, if you trust what they say, they actually say for about 7 millimeter of mercury is actually equivalent to almost 16 millimeter of a normal plain old balloon, the pressure, because so imagine if you go up to 20 atmospheric pressure, you'll be much more than the high pressure balloon really. Because of the cutting effect, I think they claim that it's actually better. There's one thing. The other thing is that I find that I'm using more and more of those low profile tri-wedge, which you can only use the 018 wire, because most of my access is through a distal radial artery, and I find that very good actually. And also slow inflation, I think, is actually quite effective. You slowly inflate, you can actually see it slowly opening up very nicely. In fact, I mean, I've been using quite a lot of tri-wedge of late lah. In fact, today only I used 2 already. Last week I used a couple or so. But I follow up one patient came for follow up today, which I noticed instantly. I did use a tri-wedge 6 months ago for BCF swing vein stenosis. Actually, there's no recurrence, and it's actually working pretty well. So I'm actually quite impressed with it. Basically,
like Sarah, I think he used a lot of scoring and DCB. So do you use DCB as well?
Yeah, that depends. That's the other point I wanted to bring out. It depends on the degree of stenosis, and also the length of the stenosis. If it is a very tight stenosis, I find that whatever you use is actually the recurrence rate is very high. And of course, if it is a long length of a stenosis, the recurrence is also higher. And for those cases, usually I will use a DCB with it together with it, because DCB actually some of the company, they actually give a 6 months of warranty.
Okay.
Can
Yeah,
I
that's
ask?
Sarah.
Can I ask Saras one question? Can I ask Saras that have you encountered any cases of balloon ruptures in this tri-wedge?
With tri-wedge, not yet, Prof. Not, I don't think so. I've done about 10 cases myself, but I have not had a rupture yet. But with our regular and even the high pressure balloons we have had before. But the one balloon that I have not ruptured before, touch wood, hopefully I don't do it another day, is the Conquest or the Atlas series.
No, what I mean to say is, if you were to rupture it, will it be very difficult to retrieve the wire and the balloon?
Like I said, I've not had a tri-wedge balloon rupture, so I'm not too sure.
I had a rupture with your tri-wedge, but it's not too bad. You can easily take it out. The reason is ruptured is because it's really tight stenosis. I actually go up to, I think up to 24, and still it didn't open up. But then yeah, it ruptured. But there's no issue of bringing it out, taking out the balloon.
Yeah, so that was my concern. I think I had a case where even up to 2024 it doesn't open. So that's why there's some, those kind of cases where we have some difficulty in terms of opening up this very stubborn stenosis.
Yeah.